Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of prime neurology. There are about 50 episodes of prime neurology. We are continuing with the third episode of prime neurology. I'm sure if you listen to all these 50 episodes of prime neurology, you would have acquired a good knowledge of neurology. So we are continuing with prime neurology part 3, the third episode, that is cortical lobar functions. So we'll talk about the all four important lobes, namely the frontal lobe, the parietal lobe, the dominant, the non-dominant. What is dominant hemisphere? The hemisphere where the language area is situated is the dominant. So most of the right-handers, the dominant hemisphere is the left. So parietal dominant and parietal non-dominant, likewise temporal dominant and temporal non-dominant, and finally occipital lobe. So we will discuss individual lobe in terms of function, the effects of damage, that is what will happen to the cognitive behavioral changes, what are the associated physical signs, and what are the positive phenomena. So first we'll start with the frontal lobe. The frontal lobe is responsible for personality. The function we are talking about is of the frontal lobe is personality. So the human being, what you are, the behavior of yours, everything is in the frontal lobe, resides in the frontal lobe. So the main function of the frontal lobe is personality, your behavior, the emotional control, how you react to a particular situation, the social behavior, and then the corticospinal tract arises from the frontal lobe, that is the corticospinal tract arises from the frontal lobe and crosses over at the level of the medulla oblongata and goes to the opposite side. So it is responsible for the opposite motor control, the contralateral motor control. And the Broca's area is in the inferior frontal gyrus, that is in the frontal lobe. So Broca's area in the frontal lobe is responsible for language, most importantly the word output, fluency. And then in the medial part of the frontal lobe we have the micturition center. So the bladder also can get affected. The urination or the micturition can get affected if the frontal lobe gets affected. The classical example is the NPH, normal pressure hydrocephalus, where the frontal horns of the lateral ventricle dilate and impinges on the micturition center of the frontal lobe. So they have the NPH, they have important components as the bladder control gets affected, bladder control gets affected, so micturition gets affected. The memory, the immediate memory is also in the frontal lobe, so they can have memory problems, and the leg area is also there in the frontal lobe, so they'll have gait apraxia. So NPH, normal pressure hydrocephalus, they'll have gait apraxia, memory impairment, and micturition important because the bladder area or micturition center is in the frontal lobe. So the functions of the frontal lobe are the personality, the emotional control, the social control. The corticospinal tract is in the frontal lobe, so it controls the opposite motor control, the contralateral motor control. The Broca's area is there in the frontal lobe, so the language, especially the fluency. The micturition is there in the medial part of the frontal lobe, so if it gets affected like NPH, they can have micturition problems. So these are the functions of the frontal lobe. When we talk about the effects of damage, what happens to the cognitive or behavioral changes? They have disinhibition. They don't have inhibition at all. For example, the bladder. We have automatic bladder, autonomic bladder, or disinhibited bladder, where the frontal lobe gets affected, so they get disinhibited. They don't have inhibition. They cannot control. They don't choose appropriate place to pass urine, so it gets released in disinhibited bladder. Likewise, even the personality, they don't have any control over their behavior, so it results in disinhibition. Sometimes they can have a lack of initiation. When we ask something, they take a lot of time to perform it. They lack initiation, what we call it as abulia. They take time to perform particular act, lack of initiation or abulia. They can have antisocial behavior. And as I said, when I was talking about normal pressure hydrocephalus, they'll have micturition problems. They'll have impaired memory also, because the dorsolateral prefrontal cortex is responsible for memory, especially immediate memory. They can have expressive aphasia because the Broca's area is there in the frontal lobe. So a lesion effect of damage of which causes expressive dysphasia, that is Broca's aphasia. Micturition center is there in the medial part of the frontal lobe. So when there's the effect of the damage to the micturition area is incontinence of the urine. So what are the associated physical signs if frontal lobe gets affected? The olfactory nerve goes to the frontal lobe, so they can have anosmia, impaired smell, especially head injury. The cribriform plate of the ethmoid bone gets affected and can result in anosmia. So one of the important causes for anosmia, other than the local causes of the nose, olfactory or the frontal lobe, is that head injury. You should always ask history of head injury when there is anosmia. As I said, it controls the opposite motor, contralateral motor control. The function of the frontal lobe is contralateral motor control, and therefore the effect of damage is the loss of control of the contralateral motor control, releasing in contralateral hemiparesis. And the other important physical sign of the damage of frontal lobe is frontal release signs. What are these frontal release signs? These are the grasp reflex or the palmomental reflex. All these are the release signs. But what are these release signs? Generally, all these release signs are present in the immature frontal lobe. So when we were just born and when we were going through our neonatal period and infancy period, frontal lobe takes time to mature. So during our neonatal period or infancy, that is less than 1 year, if we test for all these signs may be present. That is the grasping reflex or the avoiding reflex or palmomental reflex. These all indicate that the frontal lobe is yet to mature. That means it indicates as a immature frontal lobe, or on the contrary, the frontal lobe has matured but there's a damage to the frontal lobe, resulting in release of the frontal lobe signs known as frontal release signs. So when you see frontal release signs, they either indicate the brain is immature. For example, we see all these signs normally in our infancy, but after that the frontal lobe matures and these signs disappear. But if they re-emerge, that indicates that there's an effect of damage of the frontal lobe. So frontal release signs are present normally in children, but it should be absent after the frontal lobe matures. If these are present after the mature of the frontal lobe, it indicates effect of damage of the frontal lobe, resulting in the release of the frontal lobe release signs, that is grasp reflex or avoiding reflex or palmomental reflex. The positive phenomenon is that they can have seizures, often nocturnal with motor activity. Often the seizures resulting from the frontal lobe are seen in the night, so nocturnal with motor activity, and they can have versive head movements. That means head also will turn to the opposite side. Why does this occur? This occurs because there is an area known as frontal eye fields area number 8. The frontal eye fields area number 8 is responsible for turning of the eyes to the opposite side. So when there is a seizure which occurs in the frontal lobe, especially in the frontal area number 8, so there will be turning of the eyes to the opposite side. There is also turning of the head to the opposite side, known as versive head movements. Why the head also turns to the opposite side? The frontal lobe, the tract descends and supplies the sternocleidomastoid on the same side. So when the frontal lobe gets irritated, the same side sternocleidomastoid gets irritated because of the seizure activity, and therefore sternocleidomastoid activity is to turn the head to the opposite side, and therefore they have the turning of the head to the opposite side. So if you see versive head movements, it indicates that the frontal lobe is affected. So this is a positive phenomenon of effect of damage of the frontal lobe. Now we'll talk of the parietal lobe. Parietal lobe, that means dominant. That means we are talking about the left area. That is the language area, left cortex. As I said, the language area is seen in the perisylvian area on the left side. So the language, this is a function of the parietal lobe as language. Then we have the angular gyrus, which is present in the parietal lobe. Its function is calculation. So the important functions of parietal lobe, the dominant side, is language and calculation. So what happens when the parietal lobe gets damaged? The effects of damage of the parietal lobe. First, we'll see the cognitive and behavioral aspects. One, there is dysphasia, difficulty in speech, because as I said, the vernix area, adjoining area, the angular gyrus, everything is present in the parietal lobe. So they can have dysphasia, alexia, they can have dyslexia or alexia, difficulty in reading, and then they can have acalculia, because the angular gyrus is responsible for calculation, so they can have acalculia. So dysphasia, acalculia, dyslexia, difficulty in reading. In the last episode I discussed about alexia without agraphia. They can have apraxia. What is apraxia? Apraxia is difficulty to perform complex motor activity in the presence of normal motor, sensory or cerebellar function. The motor function is normal, the sensory function is normal, and the coordination is normal. Despite that, if they are not able to perform a learned motor activity, you call that as apraxia. Again, here you have ideational apraxia, ideomotor apraxia, and limb kinetic apraxia. So difficulty in performance of a learned motor act despite motor, sensory and coordination is known as apraxia. You see this in the dominant cortex. For example, when I give a real lifetime object like a brush and paste, they'll be able to perform well. But when I ask them to imagine and then perform, they'll be not able to perform it. This is known as ideomotor apraxia. In ideational apraxia, if given lifetime object, they may be able to perform, but in bits and pieces, the sequence is lost. For example, how do we brush? We put paste on the brush and then start brushing it. Here they may brush initially and then they put paste on the brush. So the sequence is lost, what you call as ideational apraxia, because frontal lobe per se is affected. But connections between the parietal and frontal lobe gets affected. The real lifetime objects, the performance is good, but when you ask them to imagine, they cannot perform. So that is known as ideomotor apraxia. But when frontal lobe per se is affected, you have ideational apraxia. So parietal lobe, if the connections get affected, ideomotor apraxia, and this is fortunately the commonest of apraxia. So they can perform with the real objects, with the real lifetime objects, but they cannot perform when you ask to imagine and then perform. So activities of daily living are not impaired with ideomotor apraxia, but with ideational apraxia, activities of daily living are impaired, because with real lifetime objects, they can perform in bits and pieces, but not in a sequential way. So this is known as apraxia, inability to perform a learned motor act despite motor, sensory or coordination being normal. Agnosia. The sensations are perceived well, but the analysis of the perception of the senses are lost. So this is known as agnosia. So this is agnosia. So again, agnosias, there are various types. Then coming to the associated physical signs, you have the post-central gyrus, so you have the sensory tracts coming up from the parietal lobe. So you have contralateral hemisensory loss. Again, a very important concept here. Contralateral hemisensory loss, basically all these primary sensations are perceived at the level of the thalamus, but few sensations are perceived by the parietal cortex, what you call as cortical sensations. That is tactile localization, 2-point discrimination, graphesthesia, stereognosis. So when the parietal cortex, dominant cortex gets affected, cortical hemisensory loss is there, especially to all the cortical sensations. So astereognosis. So when you give an object and ask them to close and identify the object, they cannot identify. If you put a key and ask them by feel to tell what object it is by closure of their eyes, they'll not be able to say it is key. So this is known as astereognosis. Agraphesthesia. Ask them again to close their eyes, write a number on the hand and ask them to tell what their number is. Generally, even if I close the eye, someone writes a number like 4 or 3, I'll be able to identify. But persons with parietal lobe lesions cannot identify the number with eye closure. Only when they see they can identify. So this is known as agraphesthesia. Then they can have contralateral homonymous lower quadrantonopia. So you know that visual pathways goes to the temporal lobe and the parietal lobe and finally to the occipital lobe. So if they are represented in the opposite way, so superior fibers are represent the lower vision and the inferior fibers represent the upper part of the vision. So parietal lobe, if it gets affected, when the upper part, so the upper fibers get affected, and therefore it results in contralateral homonymous lower quadrantonopia. And then All the sensations goes through the thalamus to the parietal cortex. So if the positive phenomenon is that they develop focal seizures, but basically sensory, because motor is to do with frontal lobe and sensory is to do with parietal lobe. So they'll have focal sensory seizures. That means they'll have abnormal sensations coming and then going. So these are also a type of seizures. So they'll have focal sensory seizures. When we come to the parietal non-dominant, so we are talking now about right cortex. So dominant cortex is that cortex where the speech centers, the language centers are situated. So usually in the right hand person it's the left side. Non-dominant cortex, that cortex where the speech centers are not situated. So normally in right-handed persons we are talking about the right side of the cortex. So basically the function of the non-dominant parietal cortex is the spatial orientation and constructional skills. So spatial orientation. So the three-dimensional view what we see is because of the parietal lobe, and the construction like putting on a dress or drawing a complex figure, everything is done by parietal lobe. In parietal lobe also, the non-dominant hemisphere is responsible for spatial orientation, not the dominant parietal lobe. I'll tell the detailed explanation, but here I would like to comment why the spatial orientation is seen in the non-dominant hemisphere. That means right hemisphere. The right hemispheres controls both the right and the left extrapersonal space, whereas the left parietal lobe, that is the dominant parietal lobe, controls only the right extrapersonal space. So when the left parietal cortex, the dominant parietal cortex gets affected, the right extrapersonal space is affected, but this is compensated by the intact right parietal lobe, which controls both the right and the left extrapersonal space, and therefore left parietal lobe lesions usually do not produce hemineglect. Whereas if the right parietal lobe lesions, non-dominant parietal lobe gets affected, what happens? Both the right and the left extrapersonal space is affected, but the right extrapersonal space is compensated by the intact left parietal lobe, but there's no compensation on the left side, so it results in hemineglect. So the function of the parietal lobe, especially the non-dominant, is spatial orientation. So when there's a damage of the parietal lobe, it results in spatial disorientation, especially hemineglect. So one of the important functions of the non-dominant parietal lobe is the spatial orientation. The other important function is constructional skills. As I said, how to construct, for example, constructing a three-dimensional figure, trying to construct a house, putting a diagram on a paper, or in fact dressing also, taking the dress and putting correctly on your body. Everything requires spatial orientation, and to put it correctly, the construction skills, all these are done by the non-dominant parietal lobe. And therefore the effect of the damage, the cognitive behavioral aspect, is the neglect of the contralateral side. So spatial orientation, as I just gave the explanation, they have hemi-neglect. On the opposite side, they'll have spatial disorientation. So constructional skills get affected, so they'll have constructional apraxia, they'll have dressing apraxia. Physical signs, the effects of damage to the non-dominant parietal lobe are contralateral sensory loss, because all the sensations goes to the opposite parietal lobe. So when the parietal lobe gets affected, they'll have contralateral sensory loss. And I said with the dominant parietal lobe, same thing applies to the non-dominant parietal lobe. They'll have astereognosis, that is they cannot identify if anything is kept in the hand and ask them to identify with eyes closed. They cannot identify the number if it written on the face or on the hands. They cannot identify it. Contralateral homonymous lower quadrantonopia, like dominant parietal lobe, and like dominant parietal lobe, they can have focal sensory seizures, because sensations goes to the parietal lobe, and if it gets affected, the positive phenomenon is the focal sensory seizures. Now let's talk about the temporal lobe. As I said again, temporal lobe, the cortex, the most of the right-handers, the language area is on the left side. So left side of the cortex becomes dominant cortex in most of the right-handers. So temporal lobe dominant means we are talking about the left cortex in the right-handed persons. So as I showed in the first episodes of prime neurology, we have the auditory perception area in the temporal lobe, the function, especially the auditory area is there. The vernix area is there, that is the comprehension of the language is present in the vernix area, which is in the temporal lobe. And memory again, there are two types, verbal memory and you see here non-verbal memory. What is verbal memory? If someone talks to me and I listen to the language, I make a memory of it. That is verbal memory. What is non-verbal memory? Non-language memory is non-verbal memory. For example, a guitar playing music or water gushing out. These are all non-verbal memory. So the verbal memory that is concerned with the language goes to the dominant temporal cortex because the language area is there. The non-verbal memory concerned with non-language memory obviously goes into the non-language temporal area, that is the non-dominant temporal cortex. Then the smell also goes to the olfactory area, so smell is also perceived by the temporal lobe. And we have the balance. I showed in the first episode of prime neurology, the vestibular area is also in the temporal lobe, so balance is also there. So what are the effects of damage to the temporal dominant cortex? We will talk about cognitive behavioral aspects. They will have receptive aphasia. Vernix area is responsible for understanding of speech. So when there is a lesion in the temporal area, understanding of speech, comprehension is lost. They cannot understand, but they can repeat. They cannot repeat also because adjoining arcuate fascicle gets affected, but they can speak well. Fluent but nonsense speech is receptive dysphasia. They can have dyslexia, difficulty in reading, and impaired verbal memory to do with the language. And what are the effects of damage on the associated physical signs? They have contralateral homonymous, this time upper quadrantonopia. In parietal lobe you have seen it is contralateral lower quadrantonopia, but here they have contralateral homonymous upper quadrantonopia. Why? Temporal lobe is lower. So the optic pathways, the inferior pathways get affected. The representation is just opposite. The nasal fibers represent temporal lobe, temporal fibers represent nasal field. The upper fibers represent the lower visual field, the lower fibers represent upper visual field, and therefore the temporal lobe, if it gets affected, the lower fibers get affected, which represents upper field, and therefore you have contralateral homonymous but upper quadrantonopia. And what are the positive phenomena? You have complex hallucinations. So smell, sound, vision, memory. You can have auditory hallucinations. All these complex phenomena can occur in the temporal lobe. You can have déjà vu phenomenon, jamais vu phenomenon. That means familiarity with unfamiliar objects or unfamiliarity with familiar objects. All these kinds of complex hallucinations can occur in the dominant temporal lobe. Now we are talking about non-dominant temporal lobe. That means we are talking about right side cortex in right-handed individuals. As I said, the auditory area is there. So the function of the non-dominant temporal lobe is like dominant temporal lobe is auditory perception, but the language area is not there on the right side of the cortex, non-dominant cortex. So you don't have the language area which is present in the dominant temporal cortex. You don't have that in the non-dominant cortex. Instead, they try to analyze the melody or pitch perception. They have the non-verbal memory. So memory not to do with the language, like guitar playing music or water gushing down. The smell, the olfactory area is there. The vestibular area is there in the temporal lobe, as I said in the first episode of prime neurology. So what are the cognitive behavioral aspects if the temporal lobe non-dominant part gets affected? They will have impaired non-verbal memory. So they cannot identify the music made by guitar or water gushing down. They have impaired musical skills because the melody, pitch, perception, everything is gone. So they have impaired musical skills, the tonal and perception is lost. So when we are talking about the associated physical signs because of the effect of damage of the temporal non-dominant temporal lobe, you have contralateral homonymous upper quadrantonopia. Again, the positive phenomenon are the complex hallucinations, smell, sound, vision, and memory. Finally, we'll come to the occipital lobe. Occipital lobe is primarily concerned with the analysis of the vision. It is concerned with vision and analysis of the vision. Though we see with our eyes, the analysis is done by occipital lobe. The procession of visual information is done by occipital lobe. So the main function of the occipital lobe is visual processing. So what are the cognitive behavioral aspect when there's a damage of occipital lobe? Everything to do with the vision is affected. They'll have visual inattention, they'll have visual loss, they'll have visual agnosia. What about the physical signs of the effects of damage of the occipital lobe? They will have homonymous hemianopia because the right side of the vision goes to the left occipital cortex, left side of the vision goes to the right occipital cortex because of the crossing of the optic pathways. So they'll have opposite side homonymous hemianopia, but macular sparing. The macula is spared because of two reasons. It has got a wide representation, and second thing, it is not only supplied by PCA, it may be supplied by the MCA also. So therefore the macular, that is the central part of the vision, is usually spared. So homonymous hemianopia with macular sparing. Unless there is a big lesion affecting the macula or occipital pole, generally it results in homonymous hemianopia with sparing of the central vision known as the macular sparing. And what are the positive phenomena? Everything to do with vision they'll have simple visual hallucinations like phosphenes or zigzag lines. So these are the important aspects of the cortical lobe functions. So now I'll talk in detail about why right parietal lesions cause hemispatial neglect. So the right hemisphere directs attention within the entire extrapersonal space, both the right and the left. Whereas if you see the left hemisphere, it directs attention mostly within the contralateral right hemisphere. So consequently, the left hemisphere lesions do not give rise to much to the contralesional neglect on the right side, because the global attentional mechanisms of the right hemisphere can compensate for the loss of the contralaterally directed attentional functions of the left hemispheres. Whereas in right hemispheric lesions, however, give rise to severe contralesional left hemispatial neglect, because the unaffected left hemisphere does not contain ipsilateral attentional mechanisms, so it cannot compensate. So right lesions will produce left hemi neglect. So how do we test clinically at bedside? So right parietal lobe lesions, they'll have left hemi neglect. So when we ask them to draw a clock with all 12 numbers equally spaced, they cannot see the left side. There's a hemi neglect. So they'll put all 12 numbers 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 all on the right side. They'll completely neglect on the left side. So this is known as hemi neglect. And if you ask them to draw a clock with numbers, they'll put all the numbers like this. So they completely neglect the left side. Balint syndrome. Analysis of vision, basically you have done by occipital lobe. It has connections with the temporal lobe and parietal lobe. So occipitotemporal, occipitoparietal. Occipitotemporal fibers or occipitotemporal connections is basically to do with what of vision. What of vision. Occipitoparietal connections are to do with where of vision. Where of vision. So the occipitotemporal lobe gets affected, what of vision gets affected. Example, the fusiform gyrus, if it gets affected, what of vision is lost. That means, for example, they may be able to see the face, but they cannot identify the face. You call that as prosopagnosia. Since what of vision gets affected, what of face is affected, so inability to identify known faces, prosopagnosia, is seen in occipitotemporal lesions, where what of vision gets affected. But if occipitoparietal lesion is there, if occipitoparietal connections are affected, where of vision gets affected. So generally when occipitoparietal connections are intact, I can see the vision in its entirety. So when I'm looking at the laptop, not only I'm looking at the laptop, but I'm seeing the other things on the right and the left side of my laptop. But if occipitoparietal lesions are present, occipitoparietal connections are affected, they cannot see the picture in its entirety. They get fixed on a particular area. So they'll be seeing only the laptop, not the surroundings of the laptop. So if they see the forest, they'll be seeing only a tree in the forest. They'll be missing the entire forest. So missing the forest for a tree is occipitoparietal lesions. So that important feature is known as simultagnosia. So if it is affected, occipitoparietal connections get affected, they have asimultagnosia. So one of the important features of occipitoparietal lesions is Balint syndrome. So it is to do with the where of the vision gets affected. So parieto-occipital lesions lead to a state of severe spatial disorientation known as Balint syndrome. So Balint syndrome is basically a triad. It involves deficits in orderly visuomotor scanning of the environment known as oculomotor apraxia, or accurate manual reaching towards a visual object known as optic ataxia, and the ability to integrate visual information in the center of the gaze with more peripheral information known as simultagnosia. A patient with simultagnosia, that is a lesion, misses the forest for the trees. So if there's an example is shown, we'll be able to better understand it. So this is it. So asimultagnosia means they cannot integrate the center of the vision with the periphery of the vision. So how can we test it at the bedside? Ability to circle small targets but ignoring the larger ones is a manifestation of simultagnosia. For example, when I have put a paper with big A's like this 1, 2, 3 and 4, and then small A's like this 1, 2, 3, 4, 5, 6, 7, and I ask a person with normal vision to encircle, they'll be able to see classically these 4 A's because it's bigger and they'll be able to encircle it. But a person with a lesion of occipito-parietal connections leading on to asymptomagnosia, they cannot integrate the periphery with the center of the vision. So when they look at the A, they cannot integrate the center of the periphery. So they get focused. Either they'll be looking at this particular line thinking it's a horizontal line, or they'll be thinking it's an oblique line and they think it is not A. But when they see the small letters, it falls in the center of the gaze, so they'll be able to encircle it. So patients with asymptomagnosia, since they cannot integrate with the center of the vision, the periphery of the vision, they cannot encircle the big A's because they do not fall into the center of the gaze. So, but small letters fall, so they'll be able to encircle small A's. So this is how we test simultagnosia, asimultagnosia. Generally, we tend to encircle big A's because they are bigger, but persons with asimultagnosia, they cannot look at the A in its entirety. They'll be looking at the horizontal line or a oblique line and think it is not A, whereas small A falls in the center of the gaze, so they'll be able to encircle it. So this is a manifestation of asimultagnosia, occipito-parietal lobe lesions. Yeah, these are the wonderful concepts of cognitive neurology. I hope you have understood it. I hope you have enjoyed listening to these concepts. If you have understood it, please like and share the link. And another important point, as I said earlier in my lecture, there are 50 episodes of Prime Neurology. We've just listened to the 3rd episode of Prime Neurology. Continue to listen these 50 episodes of Prime Neurology, and I am sure at the end of these series of Prime Neurology, after listening to these 50 episodes of Prime Neurology, you would have acquired a good knowledge of neurology. The other important concepts of clinical neurology I put in a book called Exam-Oriented Clinical Neurology. I'm the author, Dr. Sreenivas, published by White Army Publications. This book will be very useful for students appearing for clinical neurology exam. The other book I've written is Focused Neurology. All the theoretical aspects of neurology I put in a question and answer format in a book called Focused Neurology, written by me, Dr. Sreenivas, published by CBS Publisher and Distributors. This book is available online from all leading booksellers, including Amazon. So if interested, this book could be purchased online. This book will be very useful for students appearing for oral exams or viva exams. As I said, there are 50 episodes of Prime Neurology. Continue to listen to all these 50 episodes of Primary Neurology, and at the end of listening to all these 50 episodes of Prime Neurology, I'm sure you would have acquired good knowledge of neurology. I hope you have enjoyed listening to these wonderful concepts of cognitive neurology. If you have enjoyed it, please like and share the link Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel. So please like, share and subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.